In this orthokeratology case, the lenses are decentering to the side a little bit in both eyes. The left eye is a little bit undercorrected, while the right eye we're getting refractively a pretty good result in complete treatment ring in both eyes. If we look at the baseline topographies, we can see pretty strong or prominent lid imprint. So that upper lid is really pressing down on the cornea, and it may be affecting the position of this lens while the patient wears it at nighttime. Most of the time when we see lateral decentration, we want to go with a larger lens, but if we bring up the lenses that we currently have, they're already pretty big at 11.2. I think I measured this cornea right around on 11.2 or 11.3. So in this case, I would probably go a little bit smaller with the lens and go down to maybe an 11. We can thin out the edge a little bit, hopefully to minimize interaction with the eyelid. And then maybe decrease the OZ so that we have more peripheral lens to stabilize and center on the cornea. For pediatric patients, if myopic control is part of the goal, then the smaller treatment zone will enhance that as well. We do need to readjust our power. And looking at the back surface, there's some toricity now, so let's even that out. Let's see, there it is. Okay, we're a little more uniform, and that back surface looks a little bit better now, that base curve. So we are looking at a free-form view of a G-SIM lens, and around the edges actually looks pretty well aligned. So going to a free-form lens probably wouldn't help too much in this case. Hopefully these changes alone will help center the lens a little bit better and give us a cleaner treatment zone. There is a concern also about corneal astigmatism not matching the refractive. There is definitely a lot more corneal with roll astigmatism, and so WAVE predicts that we'll get about a diopter and a quarter against the rule. But a lot of times we don't correct the full amount of corneal astigmatism with a WAVE mold, with especially a spherical WAVE mold. So if there's a little bit of residual astigmatism, it'll cancel out whatever's internal, and I think we'll be left with a minimal cylindrical refraction. In the left eye, you can make the same changes, reduce the diameter a little bit. And in the left eye, since we are undercorrected, we can increase the demand by 3/4 of a diopter, flatten that lens out, and moving the OZ and IC in and adjusting our center and edge thickness a little bit. There's a really good chance this lens might still decenter a little bit towards the ears, but unless we do, for example, a scleral, we may not be able to get 100% perfect centration, but hopefully that'll get the patient with a slightly better looking topography and slightly better vision on the left eye. So hopefully that helps. Thanks for watching and best of luck.